You have tuned into The Voice of Medicine, the medical podcast filled with remarkable stories, first-hand experience, important research, and valuable life lessons. Open your mind, relax, and enjoy. Dear ladies and gentlemen, welcome to another edition of The Voice of Medicine. Today with me, Michal, and my guest from Houston, Texas, Dr. Ricardo Quinonez. Dr. Ricardo is the section head and service-in-chief in Texas Children's Hospital. He's also the associate professor of Baylor College of Medicine in Houston, Texas. Ricardo and I are going to talk today about overdiagnosing in pediatrics. He was as kind as to bring up this rather critical topic the first time that we talked, and I'm very happy that he's on my show. Ricardo, I'd like to start with first the definition of overdiagnosis. So, you, I, and our listeners are all together at the same page in regard of terminology. So overdiagnosing, as far as I looked it up, is when something abnormal is detected, but the detection does not benefit the patient in any way. So this is very different in comparison to misdiagnosing or overtreatment, right?
That is correct. So the biggest difference is that in misdiagnosis, when you actually diagnose an illness, you're diagnosing something that the patient doesn't have. You miss the diagnosis. You say a patient has asthma and they actually have reflux. Overtreatment is when you use treatments that are above the standard of care or too aggressive for something where you didn't need to use such an aggressive treatment. One of the better examples would be when you treat an infection with a very powerful antibiotic in which you could have used an antibiotic that's not as powerful and it would have treated the infection just as well. Because when you use antibiotics that are more powerful or cover for more bacteria, then you are killing bacteria that are good for your body as well. And contributing to antibiotic resistance to bacteria that you actually want the antibiotic to be effective against. And so that would be an example of overtreatment, where you're using something that's too strong, or you are using something that's excessive to the accepted standard for that illness. Whereas in overdiagnosis, what you're doing is you actually find a diagnosis that is the correct diagnosis. You either find it because you were looking for that illness, or you find it because in the course of looking for other illnesses, you find what we called an incidental finding, and you found that the patient has this other illness or other finding. So it's an actual diagnosis, it's an actual abnormality that the patient has, but the patient does not benefit from it for a variety of reasons, which I'm sure we'll talk about.
For somebody who is not from the medical field, it sounds funny. So assuming I am at the doctor's office and he finds something which is, let's say, not right with my health, right? But he already knows that there is no point of treating it. Isn't there sort of an obligation to let me know that I have something, but that it's not needed to be treated? Or like how does the medicine deal with this?
So yes, telling the patient that they have an illness is always something that is correct. We shouldn't keep that information away from patients. But it in the case of overdiagnosis, the reality is that the patient does not benefit much from the treatment that would follow that diagnosis. And therefore, we should be very open with the patient that despite the fact that we found this illness, there's no benefit from treating it. Either the patient was going to suffer no symptoms from this disease in their course of their lifetime, or by the time that they do suffer symptoms, they would probably have died from something else by that time, because it's a very slowly progressive illness, which is the most clear example of these are very slowly progressive cancers that they progress to the point that they would actually cause symptoms. Their progression is so slow that they would have progressed to the point where they cause symptoms much later after the patient has probably already died from something else related to their age. So that's just one example of many.
So as far as I saw, the whole talk about overdiagnosing was focused mostly on adults. However, the problem is also in your field, so in the field of pediatrics. And before we get to that step by step, I would like to start with the methodology. So how did research or even clinicians find out that there is a skew towards overdiagnosing?
Well, that's a great question. So there's three primary ways that physicians over the years have studied overdiagnosis. The first one is when you take a test that tests for an illness, what we call a screening test. And then you subject this test to what it's called a randomized trial, which basically you get the test on half the patients and you don't get the test on the other half. So you randomize the patients into getting it or not getting it. And then you study the outcomes. You study what happened to patients who did get the test, and you study what happened to patients that didn't get the test. And a lot of times when we have studied screening, as a matter of fact, for most screening, when you actually study it in a randomized controlled way, so in a which is sort of the gold standard for these type of things, the benefits do not seem to be there. So that's one way we can do it. We do the test. We test half the population and see what their outcome over their lifetime is, and see if they suffer from more of this illness or if they didn't, or if they died more from this illness or if they didn't, or if they benefited from the treatment resulting from knowing that they had this illness or didn't. And we can study that longitudinally over a course of several years and see what the outcomes were. And if the outcomes show that the patients who did not get this test are exactly the same or better in some cases than the patients who did get the test, then we know the test is really just causing harm, right? We know that the test is detecting an excess of illness, but the patients are not benefiting from this extra detection of that illness. So that's one way. The second way in which we study it is when we take an illness of a patient that has already had the disease or has already, for example, let me give you an example. A patient who died from things related to cardiovascular disease. They either had a stroke or they had a heart attack, and they died. And then they do an autopsy on this patient, and they find that the patients had prostate cancer. Mm-hmm. Right? And it was never diagnosed. It's diagnosed on an autopsy, which tells you that the patient always had this, but it was never diagnosed. It never caused symptoms. So we know that if somebody had diagnosed prostate cancer in that patient, they would have had absolutely no benefit from knowing that. As a matter of fact, they would have suffered harm because then they would have been exposed to the treatment of prostate cancer, which is very highly invasive. You remove the prostate, and then more than likely they do radiation therapy and chemotherapy. And so you would have suffered all the consequences of the treatment without really getting any of the benefit of the treatment. So that's one way we know. So that is what we call undetected conditions that did not cause disease.
Yeah,
that's
actually,
another way.
This example that you brought up is one of the ones that I looked up, and I mean, it kind of shocked me. So the numbers were somewhere around 10% of all men in their 20s have prostate cancer, but only 3% of men die of prostate cancer in general. So
that's correct. And 80% of 80-year-olds have prostate cancer. Mm-hmm. So that means the likelihood that you have prostate cancer, or what we call prostate cancer, when you hit the age of 80, is you have an 80% chance of having it.
Okay.
And like you said, only 3% of people die from it. So that tells you the excess amount of prostate cancer that is there. And the reason is because it's a very indolent cancer in the vast majority of patients. It grows very, very slowly. To the point that when it would actually cause symptoms or clinical disease, the patient would be way older than we currently have life expectancy.
So far you described two ways, as far as I was paying attention, of how to detect this kind of thing. What is the third method?
The third method is the one that I would say is the least the least accepted, or at least the least precise method for detecting overdiagnosis, but it's often the one that we use the most because it's easy. So basically, you notice over time that the incidence of an illness is going up. So, for example, let's say we notice that the incidence of pulmonary embolisms, which is a clot in your lungs, is all of a sudden going up. But for some reason, patients are not dying more from this, or they're not having increased consequences of the illness. So you would think if you diagnose a disease and the amount of disease over time is going up, more people are being diagnosed with it, then more people would either die from it or have consequences of it, right? The case of pulmonary embolism, I was bringing it up because it's actually been one of the cases that's been studied. So back around in the early 2000s, there was an introduction of a new type of imaging modality for pulmonary embolisms, a CT scan, which was very good at diagnosing pulmonary embolisms. It was highly effective at detecting it because the images were very good, and the protocols that they developed were very good at detecting it. And so people started using it to diagnose patients with pulmonary embolism, and sure enough, the incidence of pulmonary embolism started going way up. We started diagnosing more and more patients. But then somebody decided to study the incidence against the outcomes of it. So pulmonary embolism should in a certain percent of patients cause death because they're sudden, they happen quickly.
So by default, no matter what Medicare is available around, by default it should have certain rates of outcomes when it happens.
Right.
Yep.
You should either be admitted you should either have to be admitted to the intensive care for anticoagulation and aggressive treatment, and then you should suffer some consequence from it. But really, the best outcome to study is mortality. If you have an excess of an illness and you detect it, you should have an excess of the ultimate outcome of that disease, which is it kills a certain amount of people. But what they noticed is that it didn't happen that way. The incidence went way up. The curve was very steep as far as the incidence is concerned, but the outcomes from it stayed exactly the same, both from primary disease, which means disease that starts right on your lung, and secondary disease that where the clot comes from somewhere else. Both of those diseases went up, but the amount of mortality stayed exactly the same, which probably means that what we were detecting was an excess of disease that would have never caused symptoms. That means we were detecting very small pulmonary embolisms, which probably occur all the time in patients who are ill from something else, that they go unnoticed unless you have this very sensitive test, right? Which in this case we did.
So now you described three methods how to basically detect that there is probably overdiagnosing going on. Now, my question would be, why is it happening in the first place? So, for example, right now you mentioned tests being too sensitive. I also know from what I read that some of the standards are being lowered, and certain values are being lowered, so the threshold is lower to get through, and then the diagnosis basically has to be called out.
Yeah. So what you're talking about is what are the drivers behind the reason for overdiagnosis, and that's a great question. Well, one of them is definitely that we have this tendency to change the definition of disease. So over the years, we've changed what the definition of being diabetic means. That, it used to be a certain amount of glucose in your blood. Means when you tested it in the first morning glucose without having had a meal yet. So, for example, in 1999, the threshold for being called a diabetic went from a glucose of 140 to a glucose of 126. That means we created, just here in the United States, 1.6 million new cases of diabetes because we changed the threshold. Hypertension. In 1997, the disease threshold went from your blood pressure having to be 160 over 100 to now being 140 over 90, so lower. And that means we created 13.5 million new cases. High cholesterol, hyperlipidemia. The disease went from, if you had a cholesterol of 240, you had high cholesterol, and then it was lowered to 200. That means we created 42.6 million new cases of hypercholesterolemia or hyperlipidemia, as it's also called, 42.6 million new cases. Now, all of these, diabetes, hypertension, and hyperlipidemia or high cholesterol, are all diseases that if you increase the incidence of them, you should also see an increase in heart disease, because they are all risk factors for heart disease. Despite the fact that happened, in that same time period, the incidence of heart disease didn't go down, it actually went up. It went up by 0.2%, which means that despite the fact that now we were treating more cases of diabetes, we were treating more cases of hypertension, we were treating more cases of high cholesterol, the incidence of the disease that they all cause, which is heart disease, did not go up. Which means that we are probably treating patients that are being overdiagnosed, or in this case, sometimes misdiagnosed with something they don't actually have because we have lowered the threshold of what we call disease.
Ricardo, is this happening because physicians are afraid to miss something? Or is this happening, or is this some kind of, perhaps pressure from any kind of industry? I mean, why? I understand the mechanism that if you lower the threshold arbitrary for whatever reason, suddenly you have much more patients on the side which are basically, now labeled as, okay, you got the diagnosis, you have the disease, we got to treat you now. But why would anyone want to do that?
Yeah, so it's well-intentioned physicians who get together in panels. Sometimes there is conflict of interest because it has definitely been seen that there are certain physicians who are speakers, for example, for drug companies that treat hypertension, that treat cholesterol, and they themselves sit on these panels. So there's a little bit of conflict of interest. Now they have to disclose these conflict of interest whenever they do this. There has been some controversies about disclosure, and physicians not disclosing their conflicts of interest who sit on these panels that come up with these guidelines. So, what it ends up being for the most part is that their recommendations are not based on hard science, right? And a lot of time the recommendations are based on either observational data of, we treated certain patients who had this this disease, and we watched what happened when we treated them, and we saw if they developed heart disease or not. Well, that's not a great way to do it, because when you just take a whole population and you see what happens when you treat somebody, that's what's called an observational study. There is a variety of factors why that patient might have been treated, why that patient might have not had heart disease or the ultimate outcome from treating whatever symptom they had. The best studies to study this, again, would be randomized control trials. It would be, you have certain patients with a certain blood pressure, you decide to treat half of them, and you decide not to treat half of them, and you see whether it made a difference, right? And you randomize patients into each group so that the populations are exactly the same. They have the same risk factors. They have so you're not just following a certain type of patient over time. Unfortunately, most of these recommendations are not based on those types of studies. They're based on observational studies, or sometimes even worse, just simply expert opinion, right? Mm-hmm. You get a bunch of experts in the room, and then they decide what the threshold for a disease should be. That happens all the time. It happens all the time in pediatrics. Pediatrics, which is the field I'm interested in. There's a disease called hyperbilirubinemia, or jaundice. You've probably heard the term jaundice, which is these babies who are yellow when they're shortly after their birth, and it's due to bilirubin being in their blood. Bilirubin is a protein that is metabolized by your red blood cells when they break down, and the liver clears it. But in babies, the liver is still immature, and they're not able to clear it as much, and so some of them have their bilirubin elevated. And if it gets to a certain level, it could cause something called kernicterus, which is a disease of the central nervous system, which is fatal, or it can cause very debilitating central nervous system disease, and cause lifelong problems. So we have to decide at some point what level of bilirubin in the blood do we need to treat. And the treatment for it is anywhere from simple phototherapy. So you put babies under UV lights, and that helps the body metabolize the bilirubin and gets rid of it. Or it can be as aggressive as actually doing what is called an exchange transfusion, which is basically you take the blood out of the baby with all this bilirubin in it, and you put back donated blood. So what it's called a partial or a complete exchange transfusion. Now that's a very aggressive treatment. And so you can, depending on the level, you choose which one you do. At a certain amount of bilirubin in your blood, the protocol say you do an exchange transfusion, and a certain amount you start the baby on phototherapy. Now, how did we decide what the level should be? Now, how did we come up with these levels? Partially based on some studies, we know what the threshold is for babies to start having symptoms of central nervous system, and they're very high. And partially based on expert consensus. I know part of the people who sat on the first guideline that developed these, and basically some of them wanted a certain number, which was a little bit too high for the others that didn't want that certain number, and they met in the middle, and they decided that the curve to decide how to start treatment would be somewhat in the middle of both of their expert opinions. But the threshold that we chose to decide whether we start a baby on phototherapy or even exchange transfusion was random, based somewhat on science, but the actual level that we chose was based on a compromise between experts who had differing opinions. Some of them that wanted a really low threshold, and others that wanted a much higher threshold for start aggressive treatment. And so this happens all the time in medicine, in which experts compromise and decide on the numbers. And I'm sure that's the case of what happened with diabetes and all the other cases, such as hypertension.
So it comes down to having a solid, clear research with a correct methodology to actually get scientifically to the right threshold numbers that medicine would need. But so far, it's done, let's say, more arbitrary due to experts meeting in the middle. Okay, that's very interesting, and I'm happy that you started the topic of pediatrics. I know that one of your favorite topics is the hypoxemia, right? And the oximetry way of diagnosing this. So can you tell us more about that?
Yeah. So I think this is one of the things that I, as a researcher, have really put a lot of attention into. And it's the case of, are we diagnosing too many children what we call hypoxemia, or low oxygen in their blood? One particular disease that is the most common reason for admission in pediatrics is called bronchiolitis. Bronchiolitis is a disease of the lungs of babies. It usually occurs in babies less than 2 months, but babies up to 2 years of age can certainly present with bronchiolitis. But mostly it's babies under, I would say, even 6 months of age who mostly have severe disease from bronchiolitis because their airways are small. This virus does cause airway disease, and so they are the ones who are usually hospitalized with this. And how do we decide when a baby needs to be hospitalized with bronchiolitis? Well, a lot of the time it's based on their symptoms. They're just having a difficult time breathing. But sometimes it's simply because what we do is they show up to the hospital, and we put this machine in their finger. It's usually in their one of the fingers in the hand, or one of their toes in their foot, that detects the oxygen concentration in their blood, and it's called a pulse oximetry, and it tells us whether there's what the percent of oxygen that is in the blood after a certain series of calculations that it does by using light. It tells us what the percent is, and we have agreed based on certain parameters that we know of, that the way oxygen behaves in the blood. Mm-hmm. We have agreed as providers that anything less than 90%, if the pulse ox shows anything less than 90%, that means your oxygen concentration in your blood is low, and we put you on oxygen and we admit you to the hospital. That is true for bronchiolitis. That is true if somebody comes with asthma, or if they come with a pneumonia, any type of pulmonary disease. If your oxygen concentration is less than 90%, we say you are hypoxemic and admit you to the hospital. So a lot of us noticed that since the 1980s, we hospitalized about 300% more children with bronchiolitis than we used to in the 1980s. Now, that would be okay if bronchiolitis were somehow more severe since the 1980s, right? It's causing more severe disease. But we know that's not the case, because bronchiolitis has the severity of bronchiolitis has stayed the same since we've been keeping track.
So we're back to square one. Incidence rates are higher, but outcomes are the same.
Or in this case, the outcomes, which is hospitalization, is going up, okay. Right? The incidence of hospitalization is going up, but the severity of illness has not gone up. Mm-hmm. So what happened in the 1980s, which is when the trend started? Well, back in the 1980s is when pulse oximetry became the use of pulse oximetry became routine, because we developed this pulse ox, which were easy to use, very highly portable, so we could use them anywhere, including in physicians' offices or in any emergency room, right? And so now we have the availability of this machine, which could readily tell us whether a patient's oxygen concentration in their blood was low or not. And so now we started hospitalizing kids more, because now we could detect that their oxygen was low. Now, that would be fine, again, if we thought that doing that actually made a difference. But in fact, we know that it doesn't make that much of a difference, but because we know when we send kids home on a pulse ox who have bronchiolitis, we know that they have these episodes of desaturations all the time. So some Canadian studies, what they did is they discharged 118 patients from the ER who presented with bronchiolitis and would have normally been sent home because they weren't very severely ill, and they put pulse oxes on them, but they disabled the alarm, and then they disabled the display on the oxygen on this pulse oximetry. And then they looked at what happened. You know, the infants came back to the hospital later. They took these machines off and they read what the machines read. And what they found is that patients with bronchiolitis have hypoxemia all the time. 60% of them had desaturations less than 90% that lasted more than a minute. And 29 of the 118 infants had desaturations to 70% or less, a value for which they would have certainly been hospitalized, probably to the ICU, if somebody had detected it at the time that they showed up to the hospital. So we know that it happens all the time. And what we also saw in that study is that kids who did have hypoxemia, they were no more likely to be admitted to the hospital on subsequent visits to the doctor, and they were no more likely to visit their primary care physician because their symptoms got any worse. And so the outcomes kind of stayed the same, despite the fact that they were having hypoxia all the time.
So overdiagnosing also bears risks, right? As far as I saw, there is a high possibility on causing actual harm more than helping with anything, and especially when it comes to children. So there is a downside to hospitalizing a child, which, for example, would not have to, even if it's hypoxemic, right? Can you tell us about that?
Yeah, so the hospital is a dangerous place to be.
Do the doctors know about this?
Yeah, they do. And I think most of them agree that the hospital is a dangerous place to be because you're exposed to other illnesses in the hospital, from other patients that have more severe illnesses, or because errors can occur, right? The hospital, just like any other highly complex institution, is dependent upon humans, which can commit errors, medication error, errors of getting the wrong test sometimes, and things happen. And like that happen in the hospital all the time. We know that hospital errors occur all the time. In particular, in bronchiolitis, investigators from Cincinnati Children's looked at what the incidence of medical errors are on kids who have bronchiolitis when they're hospitalized. And it is very common. Up to 10% of kids who are hospitalized with bronchiolitis will have some type of bad outcome based on some type of error or exposure that occurred in the hospital, mostly related to acquiring other illnesses while they're hospitalized that they wouldn't have acquired had they not been in the hospital. So it happens all the time. These bad outcomes happens all the time when you hospitalize patients that didn't need to be hospitalized in the first place.
I personally would like to know your opinion about the overdiagnosing of ADHD exactly in children, because that seems to be something what a lot of parents are simply doing when they have the feeling that their child is not 100% how should I calm or just sitting in a classroom for a couple of hours. As soon as a child is a little bit more lively, there seems to be something wrong with them. So I would like to know your opinion about that. And also in regard of food allergies, I found that this is also something what seems to be going up lately as well. Suddenly everybody is intolerant to lactose or anything else. It seems pretty odd to me.
Right. So I think you've hit on two particular good on two good examples. ADHD. The example of ADHD, what I would say is that it's rather than being overdiagnosed, it's probably being misdiagnosed. Mm-hmm. Right. So a child who is rambunctious and who is very active could be diagnosed at ADHD, but it's part of their normal. It's all a bell curve, right? There's some kids who are going to be way more active than others and way more hyperactive than others, without necessarily having attention deficit hyperactivity disorder, which has certain parameters that you have to meet that are based on very clear criteria before you can diagnose somebody with that. It requires an extensive battery of psychological testing that is done by a behavioral health expert. However, kids are placed on medications for ADHD all the time without having any of this done. The parents are worried that they're very active, that they're very rambunctious. They're having bad grades in school, which that doesn't necessarily have to be the only reason why a kid would have bad grades in school. And we know this happens because ADHD diagnosis goes up right around the time that school starts, right? And so we know that it's very related to schoolwork. And so I would say rather than overdiagnosis, we are probably just diagnosing variations of normal childhood behavior as ADHD. In the case of food allergies, it's very interesting because now we have very good ways of diagnosing food allergies that are very non-invasive. We used to do skin pricks, right? Like we used to put the skin test in people's backs and then read whether the skin reacted to it. And so we used to do that all the time. And that's how we tested for food allergies. But now we have a blood test that can test for food allergies, a simple blood test that can tell you whether a patient is allergic to a variety of things right at the same time, and it tests for a whole host of food allergies. The problem is when we do this test, when the patient doesn't actually have symptoms of that disease, then what we're probably detecting is what we call false positives. Means that the blood test reacted as if the patient actually has allergies, but they probably don't, right? And we know that because there's many patients who test positive for these allergens or for this food allergy, who then you expose them to the food and they're completely fine, right? And so there's a lot of patients walking around out there who think they're allergic to certain foods who are probably not, right? And then we take the food away from them. We put them on these or we put them on these highly specialized diets to avoid these foods when it's completely unnecessary, right? And it's based on a test that's just not very good unless you have symptoms of the actual food allergy. What we call pre-test probability. It means what is the likelihood that you actually have this disease before you actually get the test. And if you test for something when the pre-test probability is low, then you are more likely to have what we call a false positive test, which is a test that the test reacts positive, but the patient does not actually have the disease. And that happens all the time with food allergy.
Ricardo, thank you very much for sharing your knowledge, your experience, and bringing up the critical topic of overdiagnosing. It was a pleasure talking to you.
Thank you. I would like to thank you, your listeners, and everyone for listening to me. I think exploring this is very important, mostly because it's in the best interest of patients, for patients to know that this can happen, and to really have meaningful conversations with their physicians. The consequences of overdiagnosis can be very severe, from being exposed to treatments that can ultimately cause severe illness and death, to simply, in what we've seen with children, what we called the vulnerable child syndrome, in which patients who are diagnosed with an illness early on in their life are considered by their parents to be very vulnerable patients. And they keep them away from activities. They keep them away from certain sports, et cetera, because they feel like these are vulnerable children because they were diagnosed early on with their disease. This is something that's been shown time and time again with children who are diagnosed early on in their life with an illness. And so if that illness happened to be an illness for which it wasn't going to cause disease in the first place, or a disease which was overdiagnosed, then this vulnerable child became a vulnerable child unnecessarily, right? And they only suffer the consequences from it. And we've seen that there's several studies that we've seen in which that happens. But as you grow older and you're diagnosed with these severe illnesses, including some cancers like prostate cancer, or in women, breast cancer, which we know is severely overdiagnosed, you're exposed to the treatment. You're exposed to the side effects of this treatment, which can be severe, which can be life-threatening, and life-limiting. And so it is a very important conversation to have with your doctor anytime your doctor suggests doing a test for an illness, particularly when it's a screening test that is to quote unquote try to diagnose a disease early on. I would have a very lengthy conversation with my physician about whether the treatment for this illness, if they do go ahead and detect it, has been shown to make any impact on my quality of life or my ultimate outcome. And if the answer is no, then it's probably a test you should not get. The Society of General Internal Medicine, as a matter of fact, is so worried about overdiagnosis or misdiagnosis that in one of their recommendations for what it's called the Choosing Wisely campaign. The Choosing Wisely campaign is a campaign where medical societies were challenged by the American Board of Internal Medicine to come up with 5 tests and therapies that we overdo, or recommendations that are not evidence-based. And the Society of General and Internal Medicine, one of their choosing wisely recommendations is do not go to see your physician on a yearly basis if you're not ill. So the general checkup, which the Society of General Internal Medicine would be the doctors who would benefit most financially from. So this was a very nice recommendation because it's against their own financial interest. Decided to recommend against the yearly physical. And one of the reasons they recommended against it is because if you go to the doctor and you're not sick, they're going to find something and they're going to want to treat you because they do screening tests. And if they do screening tests, they're likely going to find something. They're going to want to treat you, and you're going to be exposed likely to unnecessary treatments. And so they recommended against it. And so I think as Gil Welsh, who is the sort of grandparent of overdiagnosis, who was one of the first people to write a book called Overdiagnosed, where he sort of introduced this concept into the medical literature of overdiagnosis and really showed very good examples of it. A highly recommended book. Is very written in a very layman's term because it's meant for the general public. He also wrote a commentary in the New York Times, and the title of it tells you everything you need to know about the commentary. The title is, "If You Feel Okay, You Probably Are."
Extremely prosaic, and I believe him. I believe him.
There you go. Well, if you feel okay, don't go see your doctor. Coming from a doctor.
Beautiful closing statement. Ricardo, thank you very much again for your time. And
thank you for doing this.
I believe this was a really great advice for our listeners. For everybody else, thank you very much for tuning in. And this was Michael with The Voice of Medicine. Goodbye. This was The Voice of Medicine. Make sure you tune in next time and take care.